these are my disclosures. So I hope to talk about contemporary first-line combination therapies and how they've changed the treatment paradigm. I hope to talk about systemic therapy options post the first-line context. I touch on the adjuvant story and tell you where I think this disease is heading over the next few years. I'll start with a cartoon. My wife has to take credit for doing this nice slide for a paper we did in JAMA Oncology a couple of years ago. We were previously, as a field, addicted to targeting receptor tyrosine kinases on the cell surface for treating metastatic kidney cancer with VEGF and FGFR and PDGFR targeted approaches with small molecules, axitinib, sunitinib, lenvatinib, etc. Then nivolumab monotherapy arrived in the second-line setting and allowed us to target the tumor-immune interaction based on PD-1 inhibition. And then in the first-line setting, we were able to target the cancer-draining lymph node in the top left with ipilimumab, broadening the T-cell repertoire and identifying new neoantigens that we could target. Subsequently, combining these approaches, combining the small molecule and the immunotherapy approach has heralded, unprecedented improvements in overall survival in the first-line setting. And we'll discuss those in a little bit. This list of targets just 2 years ago is already out of date. And that's why oncology is so cool, especially renal cell. And I'll talk more about how it's out of date towards the end of my time with you today. So this is a slide I borrowed from Tianzhang at ASCO GU. There's been an explosion of agents in the first line and the second line in the last 2 decades. We had the sorafenib and interferon era, then we had the small molecule era, then we had the immunotherapy era, and now we have the combination approach in the first line setting. All of these from 2017 and onwards are in the first line combination setting. And now we even have new small molecules with data in the second line setting post immunotherapy combo approaches. So we've got a plethora of agents, and learning how to navigate them has become increasingly challenging. One of the ways we do navigate them, and one of the things I'm very lucky to be part of, is the International Metastatic Renal Cell Database Consortium, or the IMDC. This is our team here. This is my boss, Danny Hang, who created this based out of large real-world data sets. And it's very simple. It's 4 lab findings: hemoglobin, neutrophils, platelets, and calcium, and 2 clinical findings: colonoscopy performance status and time from diagnosis of metastatic disease to initiation of systemic treatment. You add these all up in a really simple calculator. It's on the website here, and it gives you a score, and broadly into favorable, intermediate, and poor risk disease. And it's now stratification factors for all of the pivotal trials, apart from the ones led out of MSKCC because they use another criteria, but we don't talk about them. And this way we stratify what people are likely to, from a predictive point of view, have benefit from systemic therapy approaches in the metastatic setting. So this is the first line landscape. We have immunotherapy doublet combinations on the left, ipilimumab versus sunitinib, proven OS benefit. There's a tick here if there's a proven OS benefit. We have immunotherapy VEGF combinations, and there's a tick if there's a positive OS benefit over sunitinib. So we have pembrolizumab, axitinib, that's approved and reimbursed throughout Canada. We have cabozantinib, nivolumab tick, that's approved but not reimbursed. We have lenvatinib, pembro, improved versus sunitinib, that's a tick. There was a third arm to that trial, that's called a CLEAR trial, that they don't really talk about, lenva everolimus. It's like the ugly sister in Cinderella. We don't talk about it, but that was positive too. We have negative immunotherapy, small molecule immunotherapy monoclonal antibody trials like bevacizumab, atezolizumab. We don't use that, that's not good. We have kind of questionable positive trials. We have avelumab, axitinib, that had a PFS benefit over sunitinib. That's used in resource limited settings as it's cheaper. The UK, unfortunately, where I'm from, is one of those settings where it's approved. It's approved in Singapore as well, but I wouldn't want to be on that combo because there's only a PFS gain and the OS is very similar. And we even have triplet trials. We have positive progression-free survival for cabozantinib plus ipilimumab plus nivolumab versus ipilimumab and nivolumab. That's remarkable because it was a contemporary standard of care. You can see all of these trials had sunitinib, which was the old standard of care in the first line setting. That drug is 12 years, 13 years old now. And we don't use it in the first-line setting very much anymore. Now we have contemporary standards of care, first-line, which is combo therapies. And this trial, this triplet trial, COSMIC, used a combo therapy as the comparator arm. That had PFS data. I'll go through it a bit more, but I don't think it's ready for prime time and use yet. And so briefly, let's just dive into these two trials. We have doublet immunotherapy, Checkmate 214, Ipi-Nivo against sunitinib, Ipi-Nivo induction, 4 cycles, and then nivolumab maintenance indefinitely. It has the longest median follow-up of all of these studies. It met its endpoint. It had a co-primary endpoint of OS across all IMDC risk groups, favorable, intermediate, and poor risk, but only met its endpoints in the intermediate and poor risk disease. So we don't use combination immunotherapy in favorable risk disease, or we shouldn't, and it's not approved or indicated in that context. Then when you look at the IO VEGF combos, axitinib pembro, that met its endpoints across all IMDC risk groups. So you can use that across all IMDC risk groups. And that's pembro up to 35 cycles and axitinib until disease progression. That trial also allowed, after 30, if you're lucky enough to get through 35 cycles of pembro and then had disease control and then progressed later, that trial allowed a year of re-challenge of pembrolizumab. And that's what it's funded for in Alberta anyway. And just broadly, I don't like cross-trial comparisons from a statistical point of view, different baseline characteristics, et cetera, but we all do them. So I've done them here. And I think that I've done them because I just want to show how I view these two approaches from an efficacy point of view. So they've got very similar hazard ratios, 0.63, 0.65. Ipi-Nivo, like most immunotherapies, it takes time to work. And if it does work, and it doesn't work for most people, it doesn't work very much. But if it does work, it's really likely to work well and have a durable period of disease control. And you can see here that plateau. So for about 40% of people, 45%, they're alive at 5 years, 4.5, 5 years, and they're plateauing off. Lots of censoring there, but you can clearly see here that some of those people might be long-term disease control, or maybe, dare I say it, even cure. I say that very cautiously. Pembro-axitinib, and like most VEGF TKIs and IOs, the axitinib allows early disease control. So, only 14% of people die at the end of the first year. It's much higher in Ipi-Nivo, it's about 20%. So if you have someone that's very high burden disease and that you're worried might die early, you can't probably afford to wait for doublet immunotherapy to work. You probably need some TKI because TKI works quickly. Immunotherapy takes a median of 3 months to work. And that's where the difference, I believe, lies when you're choosing, and you've got the luxury of choice here between these two approaches in the modern day. Then we have, sorry about the font here, but we have the other IO VEGF combos that have been proven in OS data from the trials. We've got cabozantinib, nivolumab, Checkmate 9ER on the left, and we've got the CLEAR study, lenvatinib, pembrolizumab on the right. With the CLEAR study, the comparisons from a statistical point of view were lenvatinib, pembro versus sunitinib, and lenvatinib, everolimus versus sunitinib. Lenva pembro wasn't compared to lenva everolimus, so we won't make that comparison. And it was the newest study, so we have the shortest follow-up, which is why you can't really compare the landmark survivals against each other very easily, because it's different follow-up. But these are the survival curves for cabo-nivo on the left and lenva pembro on the right. And similarly, you have a high level of early disease control here with cabo-nivo and with lenva pembro. Lenva pembro for 9 months, almost no people are dying from their disease, and it numerically has the highest response rates out of any, and it numerically has the highest progression-free survival of over 25 months out of any of the combo approaches in the trial context. And the median survival for lenva pembro hasn't been reached. The median survival recently was reached for cabo-nivo, and that was 49.5 months. So this is a slide I stole from Manuela Schmindinger. If you just bring all of the combo approaches together, the doublet combo approaches, we've got median OSs here, 55 months for doublet IO, 45, 49 months for IO VEGF, and not reached for the CLEAR study. Now, response rates, you see very big differences, and you see really higher response rates in the IO-VEGF consistently compared to the doublet IO Ipi-Nivo. And that's because the VEGF gives response. We know that. So if you need response early, if you think response is going to save life or organ, maybe the IO-VEGF is more important. But, you know, there is a small subset of people, these amazing, well, these responders to ipilimumab, nivolumab, that have a duration of response not even reached yet. And that has a 6-year follow-up, and this lower bound of the 95% confidence interval is 59 months for those people. So amazing, right? And then PFS, if you think progression will be the end event, if you think this patient will die if they progress, then, you know, you can't afford to wait with ipilimumab, nivolumab. Only 14% have primary, the median PFS is only at 12.3 months in that context, and the risk reduction for primary progression is only 14%, whereas, you know, the PFS for clear is 23 months. So these are some differences across trial comparisons, different baseline characteristics, et cetera, et cetera. But it's something just to consider when you're thinking about how to choose your first-line therapy. So when you just look at a bit more detail into the supplementaries of Checkmate 214, which is the Ipi-Nivo trial, you can see here the response rates for Ipi-Nivo across a number of IMDC risk factors was very consistent. You have 38 to 42% response rates, regardless of the number of IMDC risk factors. Whereas in the sunitinib arm, the control arm, you know, response rates are very high in the favorable group, 0 IMDC risk factors, but they dropped very quickly, very steeply as the number of IMDC risk factors increased. So this tells me that the sicker the patient is, the more IMDC risk factors they have, the more unfavorable their prognostic group, the more they need immunotherapy, the less that TKI alone is going to be enough. And, you know, if you're 0 risk factors, you have normal calcium, normal white count, normal no anemia, long time from metastatic disease to initiation of systemic treatment, good performance status, you're likely going to do very well anyway. You're likely going to live for many, many years. So doublet immunotherapy is not for you. You may, you know, be able to get benefit from an IO and VEGF. That is a PFS benefit over sunitinib alone. Or you can just get sunitinib or pazopanib alone because you're probably going to live for years anyway. So just the sicker the patient, though, the more IMDC risk factors you have, the more you need some immune checkpoint inhibitor, I think. That's how I see it. So how do I choose first-line therapy? Based on the risk score, you know, if you're intermediate or poor risk, you can get Ipi-Nivo. You can't get Ipi-Nivo if you're favorable risk. If you have very poor risk disease, very high burden of symptoms, I don't think I have time to wait for Ipi-Nivo to work, and you probably need pembrolizumab, axitinib, or one of the other IO-VEGF TKIs with OS data. If you you know, comorbidities are very important. If you've got a lot of cardiovascular comorbidities, brittle diabetes, bad hypertension, heart failure, maybe I don't want to give you a VEGF TKI for as long as possible, and maybe ipilimumab and nivolumab is the right thing for you. And, you know, lots of other things play into the treatment decision paradigm. You know, what is important to the patient? How far do they live from the cancer center? Do they want an oral therapy every day with chronic low-grade toxicity? Can they come to the cancer center for 3 weekly infusions initially for induction ipilimumab, nivolumab? All these things kind of play in to our treatment decision making. We wrote a paper in JAMA Oncology about this a couple of years ago. It's out of date now, but that's also outlines a bit about how we view it. Sites of metastases are also important. We had a paper in JAMA Open last year about how in patients with lung metastases, they seem to have a more favorable response to doublet immunotherapy. They have a higher response rate and more favorable outcomes. Whereas people with lung is immune infiltrated as a tissue. And we see that also in melanoma and in where we use ipilimumab, nivolumab a lot. In sites of disease like bone and liver, you know, those are immune privileged sites. I don't think the immune system can access those sites, and you probably need TKI to help you. There's some subsets that suggest that, subgroup analysis that suggests that cabozantinib is very active in bone, and Checkmate 9ER suggested that too, but I think axitinib is also active in bone, so you probably need VEGF TKI if you've got those sites of disease. So triplet, you know, it was a reasonable question, a good question that can you add in a good VEGF TKI like cabozantinib to ipi-nivo, and compared to ipi-nivo alone, and improve on outcomes. So the Cosmic 313 study was presented by Tony Chiari last year. And it was, I guess, to some extent slightly underwhelming, because although it met the PFS endpoint, median PFS improvement from 11.3 months to not reached, but it has that plateauing at the median, which probably will overestimate the PFS benefit from a statistical point of view. Hazard ratio 0.73. No OS signal as yet, no OS improvement. And we thought we'd use this in poor risk disease. We thought that this is where people need triplet, where they've got more IMDC risk factors, they've got more unfavorable disease. But the median PFS was actually, the curves crossed, and the median very much the same. Actually, the hazard ratio was in the other direction. So I don't think this is ready for prime time yet. And maybe we'll see OS data, maybe we won't. But one of the issues with this triplet is it's very toxic. Cabozantinib, giving ipi, nivo, and cabo led to a lot of treatment discontinuations. And I think that's the main limitation here. We may need to sequence rather than give all at once in this context from a tolerability point of view. So that was a really quick review of the first line setting. We don't cure enough people in the first line setting. That's the bottom line. And that's evidenced here with the PFS curves from the first line context. All of these, ipi-nivo top left, cabo-nivo top right, pembro-axi bottom right, pembro-lenvatinib bottom left, all of these studies have a 2-year progression-free survival of between 30 and 40%. So that means that 60 to 70% of people have progressed by this time. Despite lots of strides in the first line setting, we're not curing enough people with this disease, as we'll inevitably have first line refractory disease, and we need to understand how to treat these people appropriately. So this table lists all the registrational studies that led to monotherapy drug approval in treatment refractory renal cell: axitinib, cabozantinib, nivolumab, tivozanib. Look at these old standard of care drugs. They're so old. Sorafenib, it's so old. Everolimus, it's so old. I think I wasn't even at medical school when these drugs were first used. So they're not relevant to the current standard of care. And we don't know how these drugs work in the contemporary first-line context, where we're using combination immunotherapy and TKI or doublet immunotherapy upfront. Only tivozanib, so that axitinib isn't appropriate contemporary standard of care, cabo not, nivo not. Only tivozanib has data. Again, in the post-immunotherapy context, in the first line, a quarter of those patients had IO-VEGF first. So we knew this was a problem. And so we used the IMDC, which is 12,000 patient real-world evidence database, 40 different countries, 50 institutions around the world, to see, what are the current activities of TKIs post-contemporary first-line therapies. And we chose cabozantinib here in our study. So this is a paper we put out, I think, last year. So we looked at all patients. We want to look at cabo in treatment refractory disease and really look at a contemporary cohort that had been treated with first-line contemporary therapies. So all these patients were treated with second-line cabozantinib. There were 350 odd. 46 had first-line IO-VEGF. About 80 had doublet IO in the first line, and some patients had also first-line pazopanib or sunitinib. And we divided patients by their prior treatment type. We wanted to know if the first-line treatment influenced the activity of subsequent lines of treatments, and how that influence occurred. And this was sponsored by IPSEN. I do have to say they gave funding for the statistical analysis. They had no input on the write-up or comments. So as expected, when you look at the baseline characteristics, the usual table 1, you have differences in the IMDC risk, because to get first-line ipi-nivo, you have to be intermediate and poorest disease in most countries. A few favorable snuck in, probably from the US. IO-VEGF had a lot more even spread of favorable intermediate and poorest disease. And this is the Sankey plot that looked at the number of patients that really outlines the treatment patterns for patients that had second-line cabo. So all these patients had second-line cabo, and look at the number of people that didn't get any third-line therapy. 64%, 221 out of 350 people. Only a tiny fraction didn't start third-line therapy because they were still on cabo. There's a huge amount of attrition here at each line of therapy. You've got to be really careful what line of therapy you use, because these patients will probably not see, most of them don't see a third line because their performance status declines, or they die, or they have some big toxicity. So it's really important to choose the line appropriately. These are our survival curves. Figure B on the left is the OS curve in second-line cabo stratified by the type of first-line therapy with some log-rank p-values. The median OS, if you had ipi-nivo, was 21.4 months. If you had IO-VEGF, it was 15.7 months, very comparable with a non-significant p-value. On the right, the time to treatment failure. So it's real-world data. We can't have progression-free survival. We're not actually capturing progression. Time to treatment failure because of discontinuation or new therapy is a better, more accurate real-world outcome. And we found very similar median time to treatment failure by first-line therapy. So ipi-nivo 6.9 months and IO-VEGF 5.7 months. There's a table at the bottom that outlines that. We also did a multivariable IMDC adjusted Cox regression, and we couldn't find a difference in OS people with second-line cabo treatment based on their type of first-line therapy. The hazard ratio was 1.7, confidence interval 0.8 to 3.6, p-value non-significant. So we couldn't find a difference based on our assessment. It's 350 patients. You know, we may not have enough numbers to find a difference, but at first glance, we couldn't. And now it's important to put this into context. So I've done here our study, which is the first 5 rows, then the pivotal cabo study, which was Meteor, and also the contemporary cabo study in the second-line setting, which was Cantata. So our trial found, our examination found a median OS of 21 months for cabo after ipi-nivo, exactly the same as cabo from the pivotal study. So, you know, it doesn't matter if you get ipi-nivo or IO-VEGF, cabo is still as active in that subsequent line context with very similar one-year overall survivals, 66% and 73%. Cantata, this was a negative trial that looked at cabo versus cabo plus a glutaminase inhibitor. It's a negative trial, but I'm just giving it for context because a quarter of those patients had first-line IO combo for pre-cabo. And its median TTF was 9.2 months with the median OS of 24.8 months. So our data is very similar to the trial data, both from the pivotal cabo trial and a contemporary cabo trial. So I focused a lot on cabo. Does it matter that there are other VEGF TKIs, and they all have very similar approaches? My friend Jeff Graham did this nice paper in European Urology Oncology a couple of years ago, looking at IMDC again with different IO TKI, different VEGF TKIs, AXI, sunitinib, Pazo, and they all have very similar one-year overall survival. So really, you know, the choice is based on reimbursement and what you have available, and also your physician familiarity with the drug, toxicity profile, and comorbidities in the absence of sequencing data. So back to this cartoon, and this is why the cartoon's out of date. If we zoom into the nucleus, we can now target transcription factors. So there's been we know that renal cell carcinoma, one of the originator events in this disease is the inactivation of von Hippel-Lindau gene. That leads to, that normally decreases the amount of HIF2 alpha, which is a transcription factor, but with the von Hippel-Lindau inhibited or turned off, we can have increased levels of HIF2 alpha as a transcription factor. Then you get increased upregulation of tumorigenic hypoxia responsive genes, including VEGF, which is key in renal cell carcinoma development and progression. Belzutifan, here termed MK6482, is a small molecule HIF2 alpha inhibitor that particularly is encouraging from a novel treatment point of view. Previously, we were addicted to the cell surface, right? So we were addicted to the cell surface, but now we can target the transcription factor with this small molecule. And it's the first in GU tumors transcription factor targeting approach. And this feeds into where I think the field is heading, combo therapies in the later line context with this drug. Last year, we had the LightSpark study that looked at belzutifan as a monotherapy in heavily pretreated patients, median number of lines 3. And look at these swimmer plots. This is months, not weeks. You know, some patients alive at 36 months. And we can see new tumor kinetics. Blue is stable disease. Lots of these people have stable disease and then ongoing durable tumor control without response. So it changes tumor kinetics. You have a lot of stable disease here. And a median PFS of 14 months, which is very respectable in this pre-treated context with this oral agent, belzutifan. So the great and the good this year, published this study of belzutifan plus cabo, single arm phase 2, with a very respectable median progression-free survival and overall survival in a pre-treated context, with 100% of people having contemporary first-line combo standard of care, ipi-nivo or IO VEGF. And this is probably where this field is going. Combinations of VEGF and belzutifan in the treatment refractory setting. And we have this study here. We have belzutifan plus lenvatinib at Calgary versus cabo for patients with treatment refractory disease. So if you have any patients suitable that are willing to travel, please don't hesitate to send them. Another approach that may work is combining immunotherapy with TKIs. Tivozanib, which I mentioned earlier, has data as a very tolerable TKI in this treatment refractory context. And the Tinivo study was encouraging in patients with treatment refractory disease. Median progression-free survival was not reached when you combine tivozanib and nivolumab. And we have the phase 3 Tinivo-2 looking at patients that have had PD-1 in renal cell and giving them either tivozanib monotherapy or tivozanib plus nivolumab. And I'm optimistic that this may be an option for our patients down the track if the study reads out well. But I'm cautious, optimistic but cautious, because there was a negative study of atezolizumab, another PD-1, with cabo in a similar context. And that's what science is. It's iterative, it's slow, it takes time, and often it's full of failures and potholes, but we learn from these failures. So this is the current landscape as I see it in Alberta anyway, and the options available for us and our patients. We're limited in our second and third line settings based on reimbursement. In Australia, where I used to practice, you could choose your own adventure and choose whatever TKI you wanted. Whereas here it's very prescriptive, but we have some good options, but we're forced to use some in certain lines of therapy, some TKIs, based on this algorithm. So moving quickly on to the adjuvant story now, which is very exciting. So this is a short walk through history. There have been 5 published adjuvant studies in renal cell, only one of which had, from a TKI point of view, a disease-free survival benefit. That was STRAC, sunitinib, and that was negative for OS, and no one uses it. There's been one immunotherapy study with a DFS benefit, and that was the KEYNOTE-564 study, pembrolizumab. And the OS data is not mature yet. It is still pending. It's not negative. We just don't know, and we need longer follow-up. We've had a lot of immunotherapy studies in the adjuvant setting, and only one with a DFS benefit, which is KEYNOTE-564 in the top left. We've had a perioperative study. We've had a dose of nivolumab in PROSPER, and then a nephrectomy, and then more nivolumab, or just randomized to surgery alone. That was negative. We've had another immunotherapy approach. We've had atezolizumab as an adjuvant versus randomized against placebo, and then we've had doublet immunotherapy, which was negative as well. And I'll show you the DFS curves for all of these studies. So only KEYNOTE-564 was positive. The rest were negative, and there's been no OS data in any study. So how do you make sense of this conflicting, contrasting set of outcomes? Well, can we trust KEYNOTE-564? Can we trust the DFS benefit? Well, I think we can, but I think we need to be careful and proceed with caution. So already at 30 months, there's a clear disease-free survival gain with pembro, as the previous slide. With atezolizumab, despite 44 months of follow-up, there was no DFS or OS benefit. Now, in the atezo trial, there was no benefit for patients that are at the highest risk of recurrence. That really drove the positive pembro trial, like M1 resected, no evidence of disease, those with metastectomies that have had then been rendered disease-free, they get adjuvant immunotherapy, or those with sarcomatoid differentiation, they're the most immune-sensitive tumors. So I think just like in the metastatic setting, where pembro is a foundational backbone combined with lots of TKIs, and all the atezo combinations were negative, I think we're seeing some very clear differences in PD-1 versus PD-L1 activity here. I think they're not as active, PD-L1, and that's why the atezo studies were negative. So then PROSPER, a dose of neoadjuvant nivo, and then 9 further doses. This was negative too, but I think there were a lot of issues with this. There was a lot of contamination, a large portion of patients that didn't get surgery. There was no blinded independent central review. It was open label. There were delays to surgery. So I don't think the neoadjuvant approach is appropriate, unlike some other tumors. But those are some issues with the PROSPER study that could have contributed to it being negative. And then finally, CheckMate 914. So that was 6 months of adjuvant ipi-nivo. Now, this is really toxic. A third of patients discontinued treatment before the completion of 6 months due to toxicity. This was the same reason it was negative in melanoma too, I think, that same approach. The threshold for tolerating systemic therapies in the adjuvant setting is very different from the metastatic setting. People are a lot less likely to tolerate toxicity. They have no evidence of cancer. Their willingness to soldier on, to tolerate, is a lot lower compared to when they've got metastatic disease. And so that may be contributing, or just ipi-nivo may be too toxic. Maybe you need some tumor as a sink to help mitigate the risk of toxicities in that context, and you can't use it when there's no visible tumor. This is conjecture, this is hypothesis, but there's just some ideas. So I guess the take home here is that patients should be aware that pembro delays disease-free survival with a chance of life-changing toxicities, as we all know, 1% chance of diabetes mellitus or myocarditis or whatever. But there's a chance of improving OS in the future, and it's Health Canada approved and provincially reimbursed in a lot of provinces. But we still just don't know exactly, we don't know a lot about this. We don't know if we need adjuvant therapy for a lot of patients, because a lot of patients are cured of their disease by surgery. We can't pick the 5% or 8% of who would probably be cured in absolute terms by adjuvant immunotherapy. We need biomarkers, potentially ctDNA, or just better baseline clinicopathological characteristics to choose. Why are we giving it for a year? It seems very arbitrary. Is 6 months enough? Should we be giving it for longer? We don't know the right duration. We also don't know how to treat with people that recur after adjuvant therapy. A lot of provincial guidelines now are using that 6 month as an arbitrary time point. If you've recurred after 6 months, maybe you have some immune sensitivity and you can have immune checkpoint inhibitor again. If it's within 6 months, you probably can't have immune checkpoint inhibitor again. SITC had a working group recently to define immunotherapy primary and adaptive resistance, and they use 6 months also in the resistance to adjuvant immunotherapy context. So maybe 6 months is the right amount of time. I don't know. And I guess, we don't know if, we're overtreating some patients, we're undertreating others, and without good biomarkers or baseline characteristics to help guide us, we really don't know about what the best the most appropriate patient is for this therapy. As a tumor group here, we are seeing everyone that fitted the Keynote 564 criteria. So intermediate or high-risk disease, sarcomatoid, I think T3N1 or T4, any grade, or M1, NED. We're seeing all of those patients because we're having the discussion with them and empowering the patient to make the right idea for them. We may be just putting patients, as Ross Camage puts it, into a oncology time machine. We may not be curing some of these patients, but we may be delaying their disease recurrence for 4 years or 5 years. Maybe it was inevitable for that to happen anyway. But I guess personally, if I was a patient and I was able to tolerate a year and willing to invest the time and appreciate the risk of toxicity, maybe I want to be in an oncology time machine. Maybe I want to be without cancer for 5 years. That's 5 years cancer-free before it comes back anyway. This is just conjecture, and patient-reported outcomes or patient quality of life indicators clearly say repeatedly when you ask them, and lots of studies have shown this, that time spent alive cancer-free is very profoundly important to them. And I guess at the end of the day, everyone's different and everyone has a different threshold for treatment from a patient point of view and toxicity. But I think it's important that patients are empowered and have the option to see whether it's right for them. And, if we wait for an overall survival advantage, we may miss the window for curing some of these patients. There was a lot of talk. I treat some lung cancer too, small practice. And there was some talk, we talked for years about adjuvant osimertinib, whether it was just curing disease or inevitably delaying disease recurrence in EGFR positive lung cancer patients. But now we have OS data from osimertinib at ASCO this year. So I don't know what the future holds. I don't know if KEYNOTE-564 will be positive. I know that longer follow-up is needed, but I know that patients should be empowered to have the information at hand and make the right decision for them with our help. And finally, I feel very lucky to work in renal cell carcinoma in this era. In 2005, the median overall survival for patients with metastatic disease was 1 year. Now it's approaching 5 years. We're using drugs that have been the basis of 2 out of the last 5 Nobel Prizes: immunotherapy with Allison and Honjo on the left in 2018, and belzutifan, based on oxygen sensing discoveries by Kaelin Ratcliffe and Semenza in 2019. So I think we're very lucky to be able to use such wonderful science to help our patients. And I feel very lucky to work at Calgary, and this is our team from ASCO GU this year. So with that, I may just pause and yeah, happy to take any questions. Thank you.
Wonderful. Thanks very much for that overview of really a rapidly changing field, Dr. Navani. So I guess if anybody has any questions, please feel free to either maybe raise your hand and ask it, or you could also just type it into the chat, and I'd be happy to pose it to Dr. Navani. I guess just waiting for some questions to pop up. Maybe I'll get started with a couple. I mean, lots of things to pick up on your presentation. Obviously, the adjuvant piece is quite topical these days. I'm just curious, in your experience, so I guess it sounds like you see everybody that's potentially eligible, and you have this in-depth conversation with them. What proportion do you find say yes versus no after having that discussion?
Yeah, I think it's a good question. I think that the proportion would change based on the age of the patient and their comorbidities. So my patients that are under 60, absence of comorbidities, the vast majority say yes, the vast majority. I think those in their 70s and 80s that probably have some concurrent medical comorbidities, that's 50-50. That's just my anecdotal experience of the patients that I've treated on the adjuvant program. Yeah.
Okay, so quite a significant uptake. But obviously you can't always have that kind of in-depth conversation with every patient because for various reasons. What's I guess the default when someone says make the decision for me, doctor?
Yeah. And I guess that I really try and think of who is best place to receive most benefit. And if you're M1, no evidence of disease, the hazard ratio there for DFS was like 0.28 or something. Or if you're sarcomatoid, or if you're T4N1, these are the patients that really benefit the most. And I would strongly advocate that, the chance of recurrence is very high, and that recurrence can be very morbid, right? Recurrence can happen anywhere. Kidney cancer can go anywhere. I've seen it on the lip before. I mean, what a disease we're dealing with, right? And if the recurrence happens in the bone or the brain or the liver, that is really morbid. And then they're going to get immunotherapy anyway. So I guess for those patients, I do really strongly advocate for it. But like all of these patients, if there is toxicity, there's a low threshold to stop in the adjuvant setting, right? You don't want to keep going if someone's got grade 2 or 3 colitis, where you may have some evidence or some more motivation to re-challenge in the metastatic setting.
Great, thank you. So a couple of questions. I think Dr. Chung was first here. So a question is, what are your thoughts about using metastasis-directed therapy? So for example, surgery, or I guess here a lot of SBRT in the first-line setting if they have oligometastatic disease. And I guess the follow-up is, would you start, IO right away, right after they've had that therapy?
So great question. And I think a lot of it depends on the pace and trajectory of that disease. If this is the first and solitary site of metastases, and they had a long disease-free interval from the time of the nephrectomy to this metastatic deposit, and they have favorable IMDC risk, let's say, then they probably have a very favorable prognosis anyway, right? And then you can definitely have metastasis-directed therapy and have no systemic therapy and have very favorable outcome. So if you're in that category of patients, there's good real-world data to support you just having metastasis-directed therapy alone. If though you have multiple sites of metastases and you can't have local therapy for each site and the patient's symptomatic, then it would be more of a balanced discussion about starting systemic therapy soon after metastectomy or local therapy, and maybe just with a short reinterval staging to see what happens, to understand the pace and trajectory of this disease. But that I have some patients that I just do SBRT or metastectomy on and observe them, and they can have then years until the next site of metastases. And I don't want to impose systemic therapy on someone if they're going to live for many, many years anyway, and I don't think I'm going to cure them or improve their overall survival by early initiation of systemic therapy. But there are people that are IMDC intermediate and poor risk with multiple sites of disease that really probably do need to have systemic therapy earlier.
Yeah, thank you. I think Dr. Klotz had his hand up. If you want to pose your question. You're muted, Laurie.
I really enjoyed your talk. Thank you. I'm sure you saw the editorial by Ian Tannock on the Keynote 564 and the adjuvant therapy. One of the main concerns was that Pembro monotherapy is not one of the standards of care for metastatic disease, and whether by giving it adjuvantly you may compromise subsequent response to what would be considered more effective doublet therapy. So is that, how do you respond to that?
Ian Tannock's a very smart guy, so my responses won't be very smart. But I guess firstly, we will look to real world data and the outcomes for patients that have had adjuvant therapy and recur and see how they respond to IO combos. That will help inform this from an evidence point of view, because we just don't know. That data is still not even, we don't even have that data, and we have a really large database because we just don't have the numbers recurring yet, which is good, which is a good thing. The second thing is, if Pembro monotherapy, adjuvant trials always have this issue that you can't mandate post-protocol therapies, right? You can't mandate that, and a big thorn in almost all adjuvant studies in oncology is don't mandate post-protocol therapies. Did the placebo arm get standard of care combination, immunotherapy or immunotherapy VEGF in subsequent lines? And you probably will say, or everyone will say, or lots of people will say, no, when you get further follow-up. I'm sure they'll say that, okay? But I'm a pragmatist and I live in the real world, and you can't mandate what someone gets. The company that sponsored the trial isn't providing the post-protocol therapy, right? And so we'll just have to look at the numbers and see how many got post-protocol therapies. And if it's vanishingly low, then some questions have to be asked. But I think that that's one issue. There will also be some attrition. Some people just will die of high burden recurrent disease and never get a post-protocol therapy. And I need to know what that attrition or drop-off rate is to help inform my decision making. And we don't know that either, because maybe you have one chance at this. Maybe that patient will recur with bad disease and won't ever get any therapy, right? So I don't know is the answer, but those are some of the other questions I pose back, saying we're still in the dark about a lot of these things.
You're muted.
Can I just follow up? If the OS doesn't pan out as showing a benefit, would you still promote the adjuvant therapy for the DFS benefit? No, but in a certain selection of people, maybe. Like if, let's say, the sarcomatoid subgroup had lots of brain mets on recurrence, and you can delay time to brain metastases, then maybe, because brain mets are morbid and expensive and disabling. So, but broadly, no. You do need to see that OS. We've reimbursed this now based on DFS, and that's a brave new world that we all have to live with.
Yeah, no, it's an interesting and ongoing discussion. Hopefully we'll get some data at, I don't know if there's any data at ASCO being presented, updates on this. I mean, on the topic, when I looked at the slides, I think it was from ESMO, the post-protocol therapy for the control arm seemed to suggest that many patients didn't get actually doublet therapy of any kind. I mean, some obviously did, but a lot didn't. And that sort of struck me. And what it made me think is, even if there is an OS benefit for this trial, you almost wonder whether the post-protocol therapy was good enough. But again, conjecture. And,
yeah, but and it's a good point, Dr. Smoragiewicz. But I guess the thing is that to do these kind of trials with the statistical power and numbers needed, they have to be global randomized phase 3s. They're as difficult to undertake as a rocket launch, right? From a complexity point of view. And in some jurisdictions, you just don't have that therapy, right? But then you still have a patient that's trial eligible, right? And we'll always be faced with this. And I think I'm just a pragmatic here, but I don't know what the truth should be or the right answer is. Yeah.
Real world data, probably.
Yeah.
Any other questions that we would like to ask Dr. Navani? I guess I wanted to pick up on the earlier topic. You mentioned your study about real world data with Cabo, and it was interesting to see that I think you mentioned only something like 60% of patients didn't get third line therapy, right? And that's a lot of patients.
Yeah.
Is that because their performance status was too poor, or was it because they just didn't have access to another line of funded therapy?
Yeah.
And I guess the reason I'm asking this is to some extent, at least in Ontario, if you use IO TKI, you may not actually have a third line funded drug. So
yeah,
just kind of explore that.
Yeah, great questions. And from my memory, it's probably about most died or dropped their performance status, maybe 2/3, and maybe the rest either may not have had access or it was a toxicity issue. But just like Ontario, we don't have access either. And we anecdotally use, lenvatinib as a monotherapy because the company provides it for free, even though the data is with combo with everolimus. That anecdotally has reasonable outcomes too, I found. But yeah, you're right. We have to go IO VEGF and Cabo. But it's likely, and we've published data on this, that other TKIs are active after Cabo. But we just don't have access to them. And this is some of the issue here. But I guess, Cabo is very active and it needs to be dosed appropriately. And I guess I just try and keep people on the same line as much as possible, knowing I have a limited number of lines in this disease, especially after the first line. And whether that's dose titration or different schedules or metastasis-directed therapy or, whatever, that's what I'm trying to do every day when I see them.
That's great. And I guess I brought another question. So IMDC, you said 12,000 patients. That's quite very impressive. I'm curious if you have any. Do you have the breakdown of the uptake of IO or IO TKI according to geography, or what are the why would one part of the country pick one or the other?
Yeah,
or if there are trends. We
actually haven't asked that, Martin, ever. So we haven't, we could, we definitely could ask that question because we have 40 jurisdictions, as different as South Korea, Japan, most of Western Europe, some of Eastern Europe, Latin America. So we should, Australia, we should ask those questions because we do know that, every time we do a database update, we're getting hundreds of more patients on doublet IO or IO VEGF. We have, I think, 1,300 patients now on first-line combo therapies, and we have a large data set to choose from. So most of the patients we're finding, eligible for for combo IOs are getting them, but we haven't formally analyzed by geography, which is a great question.
Lots of projects. Okay, well, barring any other last minute questions, we still have a few minutes, but I guess we'll probably just close the discussion earlier unless again someone has any burning questions. So I'd like to thank Dr. Navani for his wonderful presentation. Thank you everybody for attending. Also like to thank IPSEN for making this possible, and thanks very much.
Thanks so much for having me.
Okay.
Thanks, Vish. Thanks, Marty.
Now, if you want to just stay on, Vishal.